Morning, everyone. Can you hear me? I have to do this. Okay, now, good morning, everyone. You can hear me. My name is Kathy Tamburello. I'm the state co-chair of the Regional Family Support Planning Council. Dottie Blakesley is here. She's the chairman of the Regional Family Support Planning Council. The Regional Family Support Planning Council is the legislatively mandated advocacy group for individuals with intellectual and developmental disabilities across the lifespan. We have 10 local councils across the state. So if you need more information about joining your local council and elevating your voice to be heard about the needs of your family member or yourself, please reach out to us and we would love to have you join us. We are very excited this morning. We are doing achieving integrated and coordinated services and supports for children with intellectual and developmental disabilities. All of us on the council know firsthand the challenges of raising a child with intellectual and developmental disabilities. The best results come when there is a collaborative and coordinated effort of wraparound services for the child and the family. And that is why we are very excited this morning to have such a distinguished panel. So with us this morning, we have Molly Green, the Assistant Commissioner, Division of Children's System of Care, Department of Children and Families. We have Jarrett Lynn, Associate Executive Director of Coordinated Family Care from the Middlesex County Care Management Organization. Kim Murray is here, Director of Special Education from the Department of Education. Michael Brower is with us online. He is the Legal Director and General Counsel for Disability Rights New Jersey. And we have Christine Bachter, Deputy Director of the Office of the Ombudsman for Individuals with Intellectual and Developmental Disabilities and their families. So we really have a wraparound panel and we're very, very excited about it. So without further ado, you don't need to hear from me, you need to hear from them. I think we're going to start with Molly, correct? Okay, thank you. I'll turn this off now, right?
Can you hear me through the microphone? If we leave it on the table? Perfect. That's okay, great. Thank you. So good morning to those who are here in the room with us in our beautiful professional development center in New Brunswick. My name is Molly Green. I am the Assistant Commissioner for the Children's System of Care, and I'm happy to have our audience who is also joining us virtually this morning. And we were talking this morning a little bit about how challenging it is to be able to get out on, on a Saturday early in the day, and that we're really fortunate that we have the ability to meet with families through this media, as well as to be able to share the information that we're going to be discussing today with a larger audience after the presentation. So thank you for planning that access for families who are not able to join us this morning. So when I say CSOC, that is the acronym that we use for the Children's System of Care. So I will be using that throughout my remarks this morning. So I wanted to start with just a very high-level overview of some facts and information about how we are organized and how we approach our work. So we are New Jersey's public behavioral health system for youth who are under 21 with moderate to high acuity emotional and mental health care needs and/or substance use challenges and/or intellectual and developmental disabilities. And so we do, one of the benefits of having the responsibility for serving all of these populations is it gives us the opportunity to be more agile about how we address the needs of individuals who may have co-occurring challenges. We are a division within the Department of Children and Families. So the system of care functions as a coordinated network of services and supports that relies on youth and families care. We aim to support youth and families within the community with an approach that is mindful of their unique cultural context, the social determinants of health, and we seek to promote equitable access to care for all of the children and families that we serve. We also operate in alignment with the system of care values and principles. The system of care model and these core values were initially developed over 20 years ago at the federal level as a reform effort to improve both the structure and practice of child-serving behavioral health systems. And while New Jersey did not invent the system of care model, we are known nationally as the strongest and most comprehensive implementation of this model. All of the services that we provide are available to youth regardless of their ability to pay, the family's ability to pay, and they are funded with a mix of state and federal funds. As many of you know, commercial insurance carriers do not provide coverage for some of the same in-community or residential treatment services that are offered through CSOC. 35% of youth who have intellectual and developmental disabilities who are serviced by CSOC have Medicaid or New Jersey family care coverage, and the other 65% have private insurance or some other coverage. And so one of the aspects of the model of the system of care model is we are the payer of last resort, but it is so critically important, particularly for children with very complex needs who have that private insurance, to be able to leverage those benefits and then to really extend and provide that wraparound through the system of care, the coverage that we offer through CSOC. So just a little bit of facts about how many of the youth that we serve every day have intellectual and developmental disabilities. So I looked at our data from 2023, and point in time on the last day of 2023, there were just a little bit over 17,500 youth who were open with our care management organization statewide. Of that number, 2,670, or about 15%, had established eligibility for intellectual and developmental disability services. So how do we do this? Though all of our services are funded and administered through the Department of Children and Families, the real work, as I call it, and the services are delivered through our contracted community service array. And that service array is comprised of a network of contracted providers that serve youth and families in their communities and, when necessary, in out-of-home settings. And having that community approach to a network of supports allows for the opportunity and really promotes the ability to provide earlier intervention and coordinated community-based care that is really driven by the needs of the family. And all of our partners operate within the wraparound model and utilize the core approaches of trauma-informed and healing-centered care in the way that we approach our work with children and families. So I love to meet with people in the community, and I ask them if they've ever heard of CSOC, or the Children's System of Care. And they say, no, I get all of my services through Perform Care. I'm like, that's great. Because though we do appreciate the recognition that this is a state funded and administered program. Perform Care really is the front door of the system of care. It was designed that way. There are a contracted systems administrator. And one of the reasons that the state contracts with an organization like this is because they can be much more agile and efficient at many of the functions that they provide than state government can typically offer. So they provide a number of functions. I'm sure many of you are familiar with this. They are our front door, 24/7 access to the call center, which is part of their member services functions. They also perform all of the medical necessity determinations that determine clinical appropriateness of services. They do our initial and continuing prior authorizations. They also support our number of quality management functions. They also have some very specific responsibilities around supporting the application process for children with intellectual and developmental disabilities, as well as applying for family support services. So our core community service array includes mobile response and stabilization, care management, and family support organization services. So there are 15 service areas across the state. And in each of these service areas, there is a mobile provider, a care management organization or a CMO, and a family support organization. So mobile response is our face-to-face, community-based response for children who are experiencing a crisis. It is designed to have the capacity to respond within 1 hour. And the goal of mobile response is to stabilize the youth and family system to try to keep youth at home safely and in the community wherever possible. Mobile response can stay involved with a family for up to 8 weeks. Should a youth continue to need ongoing stabilization services, they also have the ability to refer back to Perform Care and request review for CMO services and or intensive in-community services. I'm not going to talk about our CMOs because we have Jared here and he's going to be able to share a lot about what the work is that they do. And I will say a little bit more about our family support organizations. These are our family, youth, and peer support leaders. They provide peer support services to families for all of the families who are served throughout CSOC. The peer partners that operate, that work for the FSOs all have lived experience supporting their children, their youth, and this really gives them a very particular and unique experience, which informs the way that they work with caregivers to provide guidance and support from that lived experience perspective. And youth who have established eligibility for have established intellectual and developmental disability through Perform Care, through CSOC, supported Perform Care, also have access to an array of services specifically designed to meet their needs and the needs of their families. So these functional services include our intensive in-home intensive in-home clinical and behavioral services, as well as family support services. So behavioral services include ABA, other behavioral interventions that are focused on decreasing challenging behaviors, improving self-regulating skills, and communication skills. When a family is working with an intensive in-home provider, the clinician works very closely with the parent to support that behavior plan. We also have our intensive in-home clinical service line, which provides access to clinicians who can who implement cognitive and behavioral strategies. And then we also have individual support services, and these are really services that support skill development for basic activities of daily living. And so I should note here that families who are enrolled in New Jersey Family Care receive their in-community services for children with autism through their managed care organization. And we coordinate, the CMO coordinates very closely with the MCO to ensure that there is alignment, that there's one single behavior plan, and when you may be transitioning from one system to the other. There are also there are quite a number of youth who do not require the level of that level of intensity of clinical or behavioral support, who may be also receiving family support services through CSOC, and there are families that may be receiving both. So family support services include educational advocacy. It's a service that helps families whose child has eligibility for assistance with education-related needs. And that is administered by Community Health Law Project. We also provide scholarships for camp and one-on-one tuition assistance support. This is one of the areas where we've had a lot of feedback from families, and we've made some, I think, significant changes in how we manage our camp application process. Many years ago, we would open the portal in the spring, maybe in the early spring. We are now opening the portal for camp applications in September because we really want to make sure that families have the opportunity to apply as early as possible so that they can get a spot in the camp that they want their child to go to. So we sort of shifted as camps are opening up sooner and sooner, and that was in part feedback from our conversations with members of the Family Support Planning Council. So we hit our target this year. We also are able to, through the fiscal 2025 budget, we were able to increase the tuition assistance rate for camp summer, for this coming camp season. And we also did create, also with in response to feedback, we had some stakeholders and advocates saying and family members saying, my child can't really, like a day of camp is really something that it's too intense for my child. And so we created what we now have called our alternative recreational services. And we are seeking to build that capacity and that network so that children can have an option of maybe some, and not only have that service, but have an option of having 1 week of day camp and 1 week of alternative recreation. So so those of you who do have children who receive some support for camp, if there are camps in your community that you would like to be able to send your child to, it's, to the extent that you can encourage them to apply when we issue our request for camps to enroll in our network so that we can really, expand that capacity and have more camps available. So it's really a both and. So if there are camps that you're aware of that you really want us to make sure to get that application, there is an email at the end of our presentation. You can send that information to us. And then just briefly, we also provide support for assistive technology, devices, or equipment, vehicle modifications, environmental modifications. I want to just touch base on the environmental modifications. And I think it's a good example of collaboration between the Children's System of Care and the Office of the Ombudsman. So I think it was probably about 5 years ago that Paul Aronson asked me, why don't we provide support for fences? I said, that's a really good question. And some of our staff, we talked about why this had been our policy for such a long time. And I said, we need to look across the country and really validate whether the reasons that we had in the past for not supporting, not allowing this to be covered under home modifications, if in fact that's really valid and legitimate. And we looked at the research and we found that in fact, many states do consider the fencing to be a safety device and not what we were being told that had been considered a restraint. And so, I was very happy that we were able to move that forward. And so now we are able to accept applications that include requests for home fencing. We will also put fencing in a rental property if the landlord will allow us to do that. And so we're happy about that. And then finally, we do offer 4 different types of respite services: individual and self-hired respite, agency hire respite, and after school or overnight respite. And I'm very happy, I think some families may already be aware of this, that also with this year's budget, we were able to increase the hours in that 90-day authorization period for individual and self-hired respite. The governor's budget included an appropriation, which has allowed us to increase that to 90 hours within that 90-day period. And we are now that we have that additional capacity, we are taking a very close look at our respite plans to see if we can find ways to create some hybrid plans so that individuals don't have to choose only one or the other type of respite, but we can have more of a variety. So children might be able to receive individual as well as, say, weekend respite. So that's what we're looking at now. It'll take us a few months to get there, but we are very committed to advancing that system change. If you want to apply for family support services, it's a different application from the DBD eligibility application. And that's a phone call to perform care. It takes about 20 minutes to go through that. And that application is valid for 1 year. So I'm going to pause here. You'll be hearing a little bit more from me. I'm going to turn it over to Jared.
Thanks, Molly. Good morning. Again, my name is Jared Lynn. I am from the care management organization here in Middlesex County, known as Coordinated Family Care. As Molly mentioned, there are 15 service areas around the state, the Children's System of Care. So I represent just the CMO here in Middlesex. But we all work very similarly within the system. We are considered the lead partner for the Children's System of Care. We are independent nonprofit corporations at each CMO and each FSO. So we are independent from one another, but we work closely together and with CSOC and the rest of our system partners on behalf of the youth and families. As Molly said, all our referrals come from Perform Care. That is the only door into our system. And when we get our referrals for our youth, they are on a no eject, no reject policy. And that's standardized no matter what. There's 15 CMOs, like I said, across the 21 counties, and the referrals are made by geography. So CMOs receive referrals every single day through Perform Care, the contracted system administrator that Molly talked about earlier. When we receive our referrals each day, and that number varies, families are outreached that very first day, and our entire process begins immediately. We meet with them in person within 3 days of when we get the referral, and then we're out there with them doing our initial paperwork and are immediately working on family crisis planning, because that's the first step for us. That family crisis plan gets managed with the family right up front, and then throughout our process, that gets updated each time that we meet with the family as needed to make sure that that's the core of how we help keep youth safe in the community and who are open with us, and even hopefully when they're beyond their time with us. That process is the same, regardless of whether a youth comes to us with their needs being focused on intellectual developmental disabilities versus behavioral health, substance use, the other sets of needs that Molly mentioned earlier. And so regardless of what people come in with, they get the same core service. So we have this robust system that Molly talked about here in New Jersey, the Children's System of Care, and it truly is a national model. We're very proud of it, but it also has limitations. And I think it's important for people to understand that. There are examples very recently, we just finished our several-year pandemic, and during that time, especially in 2022, there were a couple of real challenges. Our entire system went through significant workforce challenges at every level. Some of that still persists, depending on which part of the system we're talking about, and it stressed every portion of our network. And at the same time, the pandemic was so hard on youth and families that we got a real burst of admissions during that period, and that combination was very challenging for us. And so we got through that, and we're moving forward now, but I want you to know that there are times when our resources get stressed more than others, and that's a good example. And there are still today workforce challenges in certain sectors of our system, and I'm going to talk about that a little bit later. So regardless of the resources that are available and all that we can provide, our entire process at the CMO is driven through family voice and choice. We implement the Milwaukee wraparound model across the entire system, which is a research-backed national model that's used in multiple states, but not as uniformly as we do in New Jersey. But one of the core values of that wraparound model is family voice and choice, and that comes through in hopefully everything that we do. So in the first month of service, a family's care manager, and every family has a designated care manager who is trained and certified as a care manager in New Jersey through the Children's System of Care, begins developing their child and family team. And this is a term you're going to hear a lot. This is the core process of the wraparound model. The child family team is a team of individuals that we wrap around a family in order to support them as their team. So our service model, when it's done right, builds a CFT, a child family team. It has a combination of what we consider both formal and informal supports. Formal supports are paid individuals, professionals like our IIH providers, BCBAs, school personnel, people like that. Informal supports, the other part of the team, include family members, neighbors, coaches, community leaders that are identified by the family as best able to support a family, to be able to support them through their journey. A real idea there of having so many informal supports is that when it does come time for a family to leave our services, that those informal supports are more sustainable, and they can stay with the family and help build on what was accomplished by the child and family team while the family was open with the CMO. That child family team composition does change over time until the right combination, if there is one, of supports and services is in place. Both the supports and the services that child family team helps to identify, and that's a core part of our work, is linking to those services. That child family team meets every couple of months throughout the time that a family is open with the CMO. And at that time, we assess progress, we adjust and pivot the services until the right combination is in place. And prior to every CFT meeting, including the very first one that happens within that first month, there's a standardized assessment that gets completed. And that's really important because it's all driven by this standardized assessment that tells us where a family needs are. That includes the youth, it includes the caregiver, and when there's particular needs, there's modules that get activated, and one of them is specifically around intellectual and developmental disabilities. And so that helps to drive our process throughout, and that's reevaluated every couple of months before every CFT meeting. I want to be clear that CMOs are not treatment providers. We don't employ any clinicians at all. We don't provide clinical services. We coordinate services. We request authorization for those services through Perform Care, and they subsequently get paid for by Medicaid generally. But that's from the larger system. But within the CMO itself, we're care coordinators, not treatment providers. And I think I can. So we're on the next slide. Now we're going to talk a little bit about how we assist families in identifying services and what happens when services aren't available, because I know that comes up a lot. Like I mentioned earlier, there are resource limitations, whether they're with our community providers, with our residential providers, and it's important that families understand where those limitations begin and end. But every CMO, including ours in Middlesex and the other 14, have access to a network of providers, whether in the community or residential, like I said. But our goal is to keep families or keep youth at home or in a home-like setting whenever possible. That's when they're the most successful, regardless of what their needs might be. There are times when youth need to go into residential out-of-home settings, but that's not our goal. Our goal is to keep families together. We meet with families in their home or at a location in the community that is best for them. Again, this is family voice and choice. This is about where families are comfortable meeting with us. We have an array of services that we have access to that can be provided in their home. And every family has a voice in which providers get selected. And really that's one of the key advantages of coming through our system and being involved with the CMO is those in-home services. Because people will ask, what's the difference? What do I get from being with the CMO, the Children's System of Care? And it does open doors to services that might not otherwise be available, including a lot of those in-home services. Each CMO also maintains a website that we call resource nets. So the one for my organization is called middlesexresourcenet.org, and then each county, almost all the counties have their own resource net, which is something that we elected to do at the local level about 10 years ago to help support the community, help support our care managers in identifying services, and also help providers who are listed on that resource net to maintain their own information so that we're confident that we put this out there. This is a portal where families, community members, providers can identify services and events that are available. But because it's driven by the providers themselves for their own entries in there, we have confidence that it's accurate in terms of what's available. It is true that typical community-based or residential services are not always available. I mentioned that a little bit ago. There's factors contributing to this. most often that there's just limited resources. And the most commonly referenced resource that gets limited is workforce issues, workforce challenges. And this has been a big theme in our system for a few years, still persists in some areas. But I will tell you that statewide, we don't have enough intensive in-home providers to meet the need. The same is true on the behavioral health side for our intensive in-community providers. And I know the state's working hard to help recruit more, and we appreciate it, but we just need more. So when there's a wait for services, it's just hard to make that connection at times. There's also a significant shortage of residential beds, again, due to workforce limitations. And this is true for all of our various types of residential treatment centers. But when there are not readily available options, we still continue to work with families. So it's not as if we try to coordinate services, we can't identify an appropriate outpatient, or not outpatient, in-community service or residential service, and we say, sorry, we can't help you anymore. We stay open with families and we look for more creative options. The initial or base level goal of keeping families and youth safe never goes away. And so we're not, that piece is our core, and our core values represent that all the time. As I talked about earlier, we maintain our crisis and safety planning. We update it no matter what from that initial visit and with each meeting that we have every other month with families. Molly mentioned earlier that there's family support services, and that includes respite, school care, after school care, recreation, summer camps, assistive technologies, all the things that Molly mentioned. And those things can be in play when a family's open with the CMO. So there are options. I do want to share a really innovative service that's now being piloted in the state of New Jersey to help manage some of these challenges with limited providers. The state is piloting a program called Intensive Mobile Treatment Services, or IMTS. And it's really interesting, and it's close to my heart because it got piloted in 2 counties, and one is Middlesex, so that's the agency for which I work, and the other is Bergen County. And it's underway just in those 2 places at the moment. And it's sort of like having residential treatment, or the array of services of residential treatment in a family's home. So a team of professionals is provided to the family, and that includes therapists, a nurse, psychiatrist, an RBT, or registered behavior technician, board certified behavior analyst, or BCBA, a resource coordinator, and even a peer support specialist. And this is another one of these services that's only accessible if you're open through a CMO. And it's a pilot. We're hopeful that the pilot continues to go well and there's sufficient funding and support to have that expanded statewide. But it's something we really appreciate, and we have 9 beds available to us as Middlesex, and Bergen has 9 as well. And we have those beds full all the time, because when a family's an opportunity, we call them beds. They're not actually beds. It's not residential, but I think of it. I think of it like residential because it's an alternative to it. So we have slots. We have 9 slots available to us, and we keep them full. And as soon as a youth leaves that service, where we don't have a lot of challenge backfilling it. We also look to consultation with the Boggs Center on Disability and Human Development, which is at Rutgers, which is an amazing resource we have in this state. Another one of our more creative options that we can utilize when in conjunction with our services when they're available and we're waiting for services. We can go to them for technical assistance for our youth with intellectual and developmental disabilities. The Boggs Center, collaborates with CMOs, provide expertise and resources, and can even participate on child family teams when we need them to. This is available through a special arrangement between CSOC, the Children's System of Care, and the Boggs Center. The other piece that you may know is that since April of 2020, insurance plans in New Jersey, managed care organizations, can now pay for ABA services without the need for a CMO. Molly mentioned this earlier. We coordinate closely with that managed care organization as an opportunity for us when we transition youth out of our services. It gives a family the opportunity to get access to ABA without all of the needs, all of the requirements of working with the CMO, because part of what I didn't mention earlier is that the wraparound process is intensive. And so when we're working with a family, there's an expectation. We have expectations from our contract and from the system. And it's also based on how wraparound works best, how our service model works best, is that we meet with families regularly in person, that we talk to them, that we coordinate child family teams. And sometimes that's a lot for families. They have a lot of things happening with their youth and their families and their homes. They have people coming and going for services. And sometimes a better option for them might be services through a managed care organization. It's MCO and CMO, so it gets a little bit confusing, but through an MCO versus the children's system of care and the CMO. And I think that's it for me for now.
I think we're moving to talking now about the relationship between the children's system of care and school systems. Before I share a little bit about that, I do want to just elaborate a little bit. I did not. I was very delighted that Jarrett was able to join us, not only because the.
I misspoke.
What? I was very.
Okay, I misspoke. That's something you're about to.
No.
I'm sorry.
No, not only because this is not only because the organization is local, his depth of knowledge, but also because they are the CMO that has had the close relationship with one of the two CMOs that's had that close relationship with IMTS. So that was a fortunate, lovely coincidence. I think a couple other things I would like to say about this program. I think it's a good example of when crisis potentially presents an opportunity. So staff within the children's system of care actually designed the program model within the division. We designed this in 2019. We were really excited about this. And then, as we all know, we went into the pandemic. The state, some of us may not recall it but those of us who were trying to manage this, we had, in the first year of the pandemic, we had that very significant fiscal crisis at the state level. We had to reduce some of our state spending as we were moving into 2021. And then as we began to see the funds coming from the pandemic relief funds flowing into the states through various mechanisms, one of the ways in which funds were made available was through the state Medicaid agencies. And so there was an opportunity for states to receive some enhanced dollars for home and community, enhanced funds for home and community-based services. And our close relationship with the Department of Human Services and the Division of Developmental Disabilities, they came to us and said, is there something that you would like to propose? And I said, I have just the thing. And so I was so glad that we'd had that opportunity to plan. And so this program is currently funded with those one-time dollars. We're able to extend those dollars beyond what we were initially told. So we're very happy about that. We're also evaluating the program, and there are a number of strategies that we are pursuing to be able to pursue opportunities to expand this model throughout the state within the available funds to do so. But we are really pleased with that program. And then another quick little infomercial. We also received some funds through American Rescue Plan Act funds that we were able to then distribute, and it took a little while to get the money out to our agencies. But one of the programs that we funded is that each family support organization has received funds that they will be using this year and into next year to create and provide community inclusion events and activities for children with intellectual developmental disabilities, their families, including their sibling members. And there's one tomorrow in Monmouth County. It's the first one at the Monmouth Museum in Lincroft. We're really excited about that. So we will certainly make sure that as we are receiving the information about the events, not only will the FSOs be distributing that, but we will make sure that that information is shared with the council so that it can get out to all of the regional planning councils. And we did ask the FSOs in the design and, you know, figuring out what they wanted to do with these dollars, that they make those plans with families in the community, so. We have a question, yes.
Can I say one little quick thing? I work with early intervention right now, and I heard about that program, and so I put it on our Facebook page to get that out to. I mean, it's mostly going to be the 0 to 3 crowd, but yes, definitely. I thought it was really, really exciting when I saw that program.
I'm very excited about it. Something that I hope we'll be able to find a way to continue to do that. So, okay, so I'm going to talk a little bit about our relationship with the schools. So staff within the division of the children's system of care, we do not have an ongoing relationship. Oh, I'm so sorry.
That's okay, Molly. I thought you were giving me like a really great intro. Anyway, you're gonna hand it off to me.
I am so sorry. I'll stop. Okay, go ahead. Sorry.
All right. So, you know, on Sesame Street, they have that one of these things is not like the others. That's me, right? That's the Department of Education in this panel. The Office of Special Ed is unique in that we do not provide any direct services to students like our sister agencies here do. We are really a regulatory body. We get the IDEA grants, and when we accept all of that money, we say we absolutely are going to implement the requirements of the IDEA, all of those laws and regulations, and we are also going to make sure that the 658 school districts in New Jersey are implementing those regulations and meeting those requirements if they want to get those dollars. Right, so first and foremost, we are this regulatory body. And we also are charged with supporting families and educators and students with disabilities. And that's hard when we're talking about 240,000 students with disabilities in New Jersey across the state. It's a big lift trying to get everybody on the same page. And I say that to sort of frame the conversation because there are no requirements in the IDEA or in New Jersey special education regulations that require this relationship between our sister agencies and school districts. School districts are not required to do this collaboration. We have no authority to make them participate in that collaboration. That doesn't mean it's not important. That doesn't mean it's not happening every day, because it is. It's just not something that we can mandate or oversee. So in these situations, I do what I always do. I go to the experts, and I reached out to many of my special education directors, some of the greatest ones that I know, and I asked them, how do you do this? How are you supporting families? How are you supporting students? How are you coordinating this? How are you integrating it? And really, it comes down to relationships and communication. That's the basis. And I think that's the basis of all of this in building successful programs for our students with disabilities, making sure they have the outcomes we want them to have, is by building authentic, genuine, honest relationships. And this is one place where that collaboration is vital. So the first thing as a family member is let the school district know that you are involved with the CMRs. They don't know unless you tell them. And so that's really, really important. Another really important piece is that the CMO, when Jarrett was talking about the CFTs, and my goodness, you guys have more acronyms than we do. I thought we were like jargony. I'm writing things down. But so Jarrett was.
If I could just say, just as a little reminder, if you're using an acronym, can you just also please just say it out So like
Yes.
IDEAs, the individual.
Individuals with disabilities are federal regulations. But, so Jarrett was talking about the CFTs, which I believe are the child's family teams. And he mentioned that school personnel are absolutely parts of those teams. So the CMO can invite district specialists, educators, providers to come to those meetings, which is fantastic. And families, you can invite members of that team and from the CMO to your IEP meetings. You absolutely have the right to do that. And that's a great way to bring everyone to the table and communicate clearly a student's needs. Next slide. I think I have 3 slides. Can you tell I was a teacher in my past life because I miss bulletin boards and projects, so I do it through my slide decks. I'm going to, bang this gong around relationships and communications again. The CMO and the districts need to communicate. They need to know what's going on in both pieces of a student's world, right? Our kiddos spend so much time in school, but they also spend so much more time at home. And so we really need to have those organizations. Again, districts can invite members to the IEP team meetings, but also you can. And I just wanna really, really emphasize this. Please invite them to the IEP meetings. Please invite them, right? That gives the district this opportunity. When you're inviting it, you're opening the door. And now everyone can come to the table. And we really get this holistic picture of a student. That doesn't happen if everybody's not there at the table. Next slide. Next slide. And then I reached out to some of my district partners, and this is what some of the things that they do, because they recognize that this is really important. This integration, these wraparound services are vital. We have districts that have a flyer that they give to families. They created a flyer, I think it's a countywide effort in Ocean County, I think. They also have, I'm sure you're all aware that New Jersey passed legislation, the threat assessment form. If they feel that a student is in crisis, there's a form and a team that looks at that form. So the threat assessment form is what they fill out, and families get a copy of that. So some districts have added information about CSOT and the CMOs to that form, so families who are not connected can get connected. We have presentations at CPAG. So CPAG is the Special Education Parent Advisory Group. That is required through New Jersey special education regulations that every school district has to have a CPAG. And that is where families can come and talk to special education leadership around issues involving special ed in the district. So oftentimes districts will have someone come to a CPAG meeting and talk about wraparound services and talk about how families can get connected with the CMOs and with CSOT. We have some school districts that their case managers absolutely make those connections and support families through the process. We have some school districts where the case managers help the families complete the applications for Perform Care to make sure that everything, all those I's are dotted and T's are crossed, every piece of paper or whatever is needed is submitted with that application. And oftentimes we have case managers linking families with the services during the IEP team. They'll talk about what services are available. They'll talk about how you can apply. So that level of collaboration is there. It may not be universal, but districts are aware, and you absolutely can, as family members and advocates for your kiddos, bring it up at the IEP meeting, right? Say, hey, how can I get connected to this? Can you help me? Does the district know this exists? Does the district know these services are available? Right, so do your part to advocate for your kid and those services and districts. I will certainly bring this up. And I meet with directors of special ed. We have meetings every 2 months. And this is absolutely going to be on my agenda because I have all of them in a room, well, virtual room, there's so many of them, but I will direct them and give them some recommendations and suggestions to move this, to make sure that they are integrating and collaborating as much as possible.
Thank you so much, Kim. Sorry for like jumping in.
That's all right.
I was having a little bit of enthusiasm.
I know.
But yeah, and it was really important, I think, that we first heard from Kim about the landscape from the perspective of DOE and all the efforts that they will continue to make, they are and will continue to make to ensure that total communication between the state and the local systems. So at the children's system of care within the division, our staff do not have a direct relationship with any of the school districts. We do have a very, very close working relationship, however, with DOE. And so as we, continue to ensure that families are getting access to information, we have done a number of things, not only for the population of children with IDD needs, but more broadly, we hosted throughout the pandemic, we hosted a number of town halls that were extraordinarily well attended. And that was before we saw that tremendous surge. But we would like to believe that one of the reasons we saw the surge to seesaw was that families and schools and systems were very aware of everything we had done to outreach and make sure that families knew how to connect with us. And so Jared's going to talk a little bit more about the CMO's responsibilities in working with the local district and coordination with the IEP planning process and the CMO service plan. And I just wanted to say that while our services, anything that we authorize is provided at no cost to families, the expectation is that services supplement but don't supplant any of the educational entitlements under the IDEA. Also, there's a link at the end of our presentation that has which individuals with developmental disabilities education act, yes. And there's a glossary, there's a link to our glossary, but I'm trying very hard to not use. My daughter has told me that I can have a complete conversation with only acronyms. And it's probably true. So if a youth is being referred to an out-of-home treatment setting, the youth sending school district is responsible for refunding the youth educational services unless the youth home district cannot be determined. And there are some cases in which that happens. And then that youth education is, the state is responsible for funding that youth education. And that is fortunately something that if we're working with the youth who's involved with the children's system of care, that means that we're also connected to the Department of Children and Families and that capacity to coordinate for children who are, that the Department of Children and Families has a role in that coordination for children who may not have a permanent district. So we have subject matter experts within the department who can help us with that. The CMO will also, in those instances, try to assist with determining, where is the responsible local or state entity. And then the CMO will coordinate with the youth school district and the youth parents to obtain those necessary approvals and documentation that would enable a youth to be registered with and attend the appropriate school environment while in an out-of-home setting. And I think this may be something folks are going to want to talk a little bit more about when we get to the Q&A, because there are a lot of issues that can come up for families when they are trying to negotiate an out-of-district placement with their schools. So I'll kind of hold that if that's something folks want to talk about some more, and then turn it back over to Jared.
So I loved hearing him talk about or encouraging families to talk to their child study teams or their schools or districts about making sure they know that CSOC services, CMO is available. And we have to look at it from the other side of it as well. So I talked earlier about our child family teams and who was on them. And it's so important to us to have people from the schools on those child family teams. And that could be, it can be a teacher, it can be a social worker, it can be a coach or club leader, it can be directly related to the IEP process. But we really need families to let us know, and we have complete conversations with our families, but sometimes it's left out that a youth is at a particular school district or a school with an IEP, and we don't make that connection. So it's important that, yes, a family lets the school know that we're available, and that when we are connected to a family, that the family lets us know how we can best assist them with the school, because again, it's about their voice and choice and connecting all that together. Like I said, ideally, we have somebody from the school on our child family team, and at the same time, our care managers can participate and should participate in IEP meetings. And so that's a great opportunity to best connect these systems together. That's the expectation we have for our care managers when there's an IEP. So I want to make sure you understand that there is that strong connection. It doesn't happen without all the information being shared among the members of the child family team about these interconnecting systems.
You get to listen to me again. So this is an important conversation. And one of the things that is most important for families to understand that when you're exploring out-of-home placements, the school district is ultimately responsible for providing a free, appropriate public education or FAPE, right? It's the school district's responsibility. That responsibility does not, they're not relieved of that responsibility because the student is no longer attending the school or is no longer residing in the school district. So that conversation, the school district will still be involved when a student is removed from the home and is placed somewhere else for a residential piece. What should happen is that the case manager and the family will come together. They'll look at what are the needs of the student. They'll look and see where is the student geographically, where is the student residing? What are the educational options that will best meet the student's needs? It could be continuing in the home district if distance isn't too great and the student is supported educationally. It could be in an approved private school for students with disabilities, if that's most appropriate. It could be in the district where the student is residing, if the student can be supported appropriately. So there's no one answer as to where a student will be educated. That is something that the case manager and the IEP team will determine. Because ultimately, the goal is for the student to return home, return to their home district or wherever they were receiving services prior to being in and out of home placement. So you want to keep that communication robust between the district of residence and wherever the student is currently receiving services. So really a best practice would be to make sure or to try to have the district, the home district case manager participate in any IEP meetings for that student that occur in another district or in an approved private school, so that there's communication and the student will be well supported when he or she comes back to their home district. I'm just gonna do a quick time check here. It is 11:06, and we want to make sure we leave some time for questions, so we have about 25 more minutes, okay? I know there's just so much to talk about as we go on all day. So it looks like it's back to seesaw.
We skipped this. We're going back a slide. Yeah, we're going back.
We're on out-of-home placement seesaw.
Okay, so
There we go.
okay. So I did not try this long. So, well, less than, fewer than 6% of the youth who are served by the CMOs overall, are served in out-of-home settings. Children with intellectual and developmental disabilities are more likely to receive those out-of-home services. And of those children who do go out of home, about 25% of those youth have co-occurring intellectual and developmental disabilities. So the CMO care manager is responsible for facilitating the out-of-home referral process. This includes creating the out-of-home referral, submitting it to Perform Care for a review. Perform Care then completes their intensity of service determination, which will recommend one of the levels of care or program types that you see here on this slide. And the CMO, once that intensity of service determination has been made, the program, well, I try to say this as quickly as I can. So the CMO is going to be responsible once we've identified the type of program, and at the division level, we identify the individual programs that offer that level of care, and we provide that to the CMO. They are then responsible for contacting the programs once those recommendations are made, and arranging the meet and greet interviews with the residential programs and with the family. And when this also happens, the youth remain on what the reason it kind of goes from Perform Care, so it goes from the CMO to Perform Care to make the determination of the right level of care. Then it comes back to the division, and we look at that youth's age, their gender, other factors. Where do we want to make sure that youth are placed with a peer group, so that they're in a group with others that they will be able to have a successful relationship and treatment experience with. And that's when the CMO will then identify the meet and greets for those agencies. And once a youth and a family accepts a program placement, the youth and the family, along with the program, work together to establish that admission date. So as you can see, we offer this very robust continuum of treatment programs that provide varying levels of care, and supports based on the homogeneous needs of the individuals being served in that particular program type. So they're listed here from the least to the most intensive program settings. And some of these programs do also offer co-occurring services. We are very transparent at DCF about sharing how we make our decision making. All of the clinical criteria for all of our all CSAP services, God bless you, are posted on the Perform Care website. So that's all available for families, and for the general public. And so they address, and you'll see if you look at the criteria, well, what does that mean? How are we making these decisions? We are looking at what are the individuals presenting emotional and behavioral symptoms, their functional capacity or impairment in school, community at home, as well as certain exclusionary criteria for different program types. And so I'm gonna, in the interest of time, I'm gonna move it along.
So just looking again to see what we can move along a little bit. I already talked quite a bit about seeing the child family team process and wraparound. And so I'm not gonna go into that more, but what I will say is that that model works when it's done the way it's supposed to be done. That is the definition of high quality wraparound and work for us. It's like I said, it's a research-based model, and we try very hard to make sure that we follow that model. State expects us to follow that model, but it's very important to us at the local level too. When there are concerns with a particular service or clinical intervention, the child family team has to share that with the care manager. Part of the care manager's role for families is advocacy. And so they don't just connect families with providers, but advocate on their behalf with them. They have the support. We're a team-based organization. Every care manager is on a team with a supervisor and peers and a coach to work with them so that they all work together to advocate for your family, for a family, when there's a need for it, when there is a concern about quality of care or appropriateness of care, or even just fit. I want to remind you that none of the providers work directly for the CMOs. I know I talked about this earlier. We just coordinate them. Maybe not just, but we coordinate them. We make every effort at each CMO to maintain a network of high quality, community-based providers. We have formal agreements with everyone that dictates how we are, how they know these providers that we're going to hold them accountable for those high quality of services. And when there's a challenge to whatever aspect of their service that's occurring, we can look back to that agreement and say, we have an expectation of you that you're going to be providing this level of care, this quality for our families. And that gives us a little bit of extra ability to advocate, because we're the place where those providers get their business. And so they're motivated to provide high quality care, but it's up to us to also help monitor that and advocate for you or for families.
So, and when we talk about the way that we approach, not just ensuring, but promoting and quality improvement, I often think of the system of care as being like a little bit belt, suspenders, and a bow tie. Because as Jared just shared, the CMOs at the local level have agreements with the providers that, have agreements with providers that are in addition to the contracts that we hold at the department. So they're able to address a lot of those issues around access, performance, follow-up. And when those things escalate to a point where, we need to be brought in because it's really a network of, provider performance issue that implicates their contract with us, then we can also become involved in addressing those situations or circumstances. First, I want to talk a little bit about perform cares at work. And so there's the work at the local level, there's what CMO is able to do with those in-community providers, and then what is available through perform care. So they are contracted to implement a quality improvement program that systematically monitors and evaluates the quality of clinical care and service delivery by perform care staff and CSOC service providers. For example, they are clinically reviewing every service plan that is prepared by and submitted by the care management organization to ensure that it is in alignment with and able to meet that child's needs according to the medical necessity and clinical criteria. So not only do they monitor the quality of care and services, they elicit and use family feedback to inform their quality improvement efforts through their family council. And this is all available on the Perform Care website. I'll be linked to that as well. If a family has a complaint, what we recommend, and this is outlined in our Youth and Family Guide, is to try to address that issue with the person or the agency where that complaint or concern is arising. If the family member is not satisfied with the result, you can submit a complaint to Perform Care. And I want to make it clear, these are the suggested steps. It's not, like if you feel that you need to make a complaint, make a complaint. So you don't need to demonstrate that, but we do encourage to try to resolve those things because hopefully they can be resolved more quickly. But you can also make a complaint to Perform Care depending on the nature of the concern. That may be the best and the first way to address it. You might have a complaint because you're dissatisfied with one component of care, Could be quality of a service, timeliness, or provider performance. So you can file a complaint regarding any service Perform Care has authorized. You can just simply by picking up the phone and making a phone call. You can also do that in writing. You can ask to file a complaint at any time. You can also request a reconsideration if you don't like the decision regarding an authorized service. Or, in some cases, if there's been a denial of service, a termination or a reduction, families have the rights to appeal or a fair hearing. And so all of this is outlined in the Youth and Family Guide, which is available on that website. I also want to mention, however, I'm not sure if this, I think this is the suspenders, but is that we also have at the Department of Children and Families an Office of Constituent Affairs. We offer additional resources to families. This office manages all internal and external inquiries for the division. It is the office that Christine and the team within the Office of the Ombudsman typically reaches out first to our Office of Constituent Affairs. And so we are also available, and we're going to share information on how to connect with us. And within this office, I want folks to be aware of some of the other supports that we have. This is the office where our specialist on transition to adult services works in this office, a liaison to the Bureau of Guardianship. And we also have a staff person who acts as a family liaison when there's a need for some shorter term support that really requires assistance from at the state level. So she will also connect with families.
So I want to talk quickly about transition from our services. Transition is the term that we use for discharge in our wraparound model, and it's important to us to use our language. And it's a conversation that comes up a lot, particularly with our families with youth with intellectual and developmental disabilities versus our youth with other kinds of needs, because those particular needs tend to be more lifelong and long-term. And so there's confusion sometimes about whether we do transition, whether we do leave our families do leave our services and what that might look like. But like other services throughout our industry, the conversation about transition or discharge starts from the very beginning. I'm just trying to shortcut some of my comments here. It's driven by those ongoing assessments that I talked about, and CMO services are not intended to be there till adulthood. When we can determine through our assessment process, through observation, through the family's voice, which is important through every step of our process, that a youth is safe, healthy, connected to services, that we talk about transition to a sustainable community approach that may or may not, that does not include us, but that may include connection to a managed care organization like I talked about earlier. Remember that CMOs are on a Medicaid platform. And so that Molly mentioned it earlier, that Perform Care needs to be able to determine that a youth still meets medical necessity for Medicaid in order for you to stay open with the CMO. So it comes to a point where a youth may be doing so well that they no longer meet that medical necessity, and we really don't have justification to keep them open with the CMO. But that whole conversation should not be sneaking up on families. We have this conversation from the very beginning, like I said, with the intention and the transparency that at some point, the youth may need to transition from our service. Our most common dispositions that transition from our service for youth with intellectual and developmental disabilities is aging out, or which is at age 21, or transition or transfer to a managed care organization. What is really nice about this particular population that we're talking about is that we have a very defined and formal transfer process from the youth system to the adult system to BDD, the Department of Developmental Division? Division for Developmental Disabilities. And it's much more robust and organized and defined than it is for our behavioral health youth. And so it's for our IDB youth, it's really very planful. Always remember that CMO services are voluntary and they're free, or they're at no cost to families. And that families are permitted to re-enter our system by calling Perform Care. We know that in our work, we have re-enrollments. So a transition isn't permanent for many of our families. And so that Perform Care number is still open to.
Great. Thanks, everybody. I just want to double check that you can still hear me since I'm remote. I see thumbs up. Great. I appreciate everybody giving this big outline. And I want to start off just by introducing Disability Rights New Jersey for anybody who is a person in the virtual audience who has not heard of us. Disability Rights New Jersey is a private nonprofit. We are also the state's designated protection and advocacy system for people with disabilities. And there is a designated protection and advocacy system in every state and every territory of the US. Our job is twofold. One, our main goal is to prevent or stop abuse and neglect in any setting that serves a person with a disability and with any kind of disability, not just intellectual developmental disabilities, mental health diagnoses, physical disabilities, traumatic brain injuries, health conditions, you name it, very broad-based. And as part of that obligation to stop abuse and neglect, we get to go unannounced and unaccompanied into any setting that serves people with disabilities just to look around. If we have probable cause to believe that abuse or neglect is happening, we can conduct our own investigations. But remember, we're not part of the state. We're a private nonprofit. So our investigations often result in findings that go to state government, the appropriate oversight agency, whether that's the Institutional Abuse Investigation Unit for youth facilities, whether that's the Department of Human Services and Adult Facilities or Department of Health. In other settings, those investigations are meant to get the authorities to act, the people who have the levers of power to stop those abuses. The other part of the protection and advocacy system is essentially a private nonprofit law firm, and that's where I work. I'm the legal director. And so my job is to oversee the representation that we conduct on behalf of clients and on behalf of the population of people with disabilities at large in New Jersey. When it comes to talking about children's services, the children's system of care, through the educational systems, Disability Rights New Jersey has an Olmsted goal. Our representation of individual clients ranges from advice, trying to help somebody solve their own problem with some guidance and how to navigate a system that's not working for them, through limited representation, maybe a couple of outreaches, some phone calls, try to solve the problem on somebody's behalf, or extended representation. Extended representation is what you would think of in your normal client-lawyer relationship, where we take on a client, we file appeals, we go to bat, basically we go into the ends of the earth to solve a problem for a client until the problem is solved or until we can't solve it and we decide that we're at the end of our road. So for people who are having problems with the services described above, whether it's getting your school district to find the appropriate placement, whether that's getting enrolled with the CMO or getting through the Perform Care gateway, whether that's having difficulty finding the right service or having difficulty working with your CMO to find the right service in the children's system of care. I would encourage you, I put our phone number, it's the 1-800 number works inside New Jersey, the 609 number works anywhere, and our website where you can also ask for an intake online at disabilityrightsnj.org. I would encourage you to reach out to us. Our services cost nothing. We are funded by the federal government, some private grants, and a few grants through the Bar Foundation here in New Jersey. When it comes to representation, I mentioned that our goals here are focused on integration and Olmsted. It's important to know that under federal law, institutionalization of people with disabilities is illegal segregation. The Olmsted case, where we draw down that conclusion under federal law, was looking at whether there were sufficient state services in the community for people with disabilities who wanted to live in the community, in their own homes. And it's so good to hear Molly and Kim talk about like the intensity of services being focused on keeping children with disabilities in their own homes as much as humanly possible. If there's services available in the community aren't enough, if there's not capacity to serve people with disabilities in those settings, that gives rise to a federal legal problem. We have Disability Rights New Jersey has in the past filed lawsuits against the Department of Human Services. We're currently in a lawsuit against the Department of Human Services and the Department of Health because the systems that serve people, in this case with mental health disabilities, is inadequate to meet their needs in the community, resulting in more people in more restrictive settings like psychiatric hospitals than really is necessary. And so under the Americans with Disabilities Act and Olmstead, the state really has an obligation to make sure that those systems have the capacity they need to serve the people with disabilities who want to and can live in their own homes or a community home. And when we're talking about children, it's typically the family home. So it's important to know that's kind of what colors the background of everything we do in this space. I'm going to talk about the appeal process in the slides, but there's a couple of punch points I want to get in quickly if possible. One of the things that I think we can contribute to this conversation, because we're a law firm, like most lawyers, right? We get people coming to us when things have gone wrong, when the system has broken down and the way it's supposed to work doesn't necessarily pan out in reality. And so I want to just give a couple of examples of some situations that we see. The most common example when it comes to the children's system of care or families who are looking for an out-of-home placement for their child, especially in the IDD community, is that there aren't enough services, right? Thinking about it under that Olmstead analysis, the capacity just isn't there. Youth who have the most intense needs, the most ongoing and consistent need for behaviors to prevent, harm to themselves or harm to the family or harm to the home, it's just not available. Very long wait lists for those kind of long-term services and supports. Oftentimes, our clients are the ones who have gone through every possible provider in the CMO's network, right? The in-home services have come out and they've turned around the same day and left and said, we can't handle this case. We're going to quit. And the family is left on their own to figure out what they're going to do. The search might continue, but oftentimes, even if there's a identified placement that might be the right fit, the wait list is very long, sometimes months, sometimes years. And in the meantime, often our families and our clients are telling us, well, we're having a hard time engaging with our CMO to find something that's a stopgap measure. Like, what are we going to do in the meantime while we're on this wait list? Is there any kind of short-term service that we could get in the home so that, it's not, me, the parent, and my child with very intense behavioral needs just hanging on by a fingernail. And oftentimes we find that planning really isn't going on, or again, those services aren't available either because the family may have gone through everything that's within the CMO's network. Another acute issue that we see, it seems to be structural, is that families will call, families who are in the system, they've gone through Perform Care, they've been enrolled with their CMO, they're in the situation where they're hanging on by a thread, and a crisis comes up, and they call Perform Care hoping to get some kind of access to the mobile response system, and are redirected because they are already with the CMO back to the CMO, and the CMO has already done probably all they can do in terms of tapping the network to find supports and services. And so the family who's engaged with the CMO doesn't have access to that mobile response anymore. Problematic when you're in crisis and your only choice is to call 911. I'm sure families who have been in that situation know it's hairy. You don't know exactly what that response is going to be like. Often a police officer may be the first person to respond to a 911 call for crisis, and you just don't know exactly what you're going to get. And the last kind of factual situation we see, and it's relevant for this conversation here, when a student is classified as special education, they're looking for individualized education programming, likely out of home, even if the district agrees the student needs to be served in an out-of-home residential setting so they can receive their free, appropriate public education. And the CMO is on the same page. The student really cannot be served in the home. There's not in-home services that meet their needs. That the coordination just doesn't happen. Despite all the best efforts, the CMO wants the district to go first. Maybe the CMO is tapped out on all of the out-of-home placements they know of. They maybe are prohibited from advocating to grab the next available slot at that placement they know will work. And the district has a financial incentive to avoid placing a student out of home because once they do, they might bear that cost on their own. And therefore the taxpayers will bear that cost, and that might be very unpopular. And so essentially, the student's left holding the bag. The district doesn't want to jump. The CMO is out of options, wants the district to take the next step. And there's nowhere for the student, whoever one agrees needs the out-of-home placement to go. And there's no short-term services coming their way anytime soon. And so often that's the client that we receive. We're trying to work with them to troubleshoot, right? To stop the barriers that are coming up. Oftentimes the appeal process, and that's what I'm going to transition into next, comes in. Because when the system breaks down and you find yourself either as a parent or a person who's being served by these systems in a bad spot because services aren't available, or maybe the termination process from care management has happened to you involuntarily. You've been talked into it or told you have no choice, that no services are available. I saw a few questions come up in the Q&A about what happens when services aren't active for a long time and if CMO's got some incentives to push somebody out of services. The good news is you have a right to appeal. Because the services through the children's system of care are largely Medicaid funded now, there are federal appeal rights that guarantee the right to due process. One important part of due process is that when a service is denied, reduced, or terminated, meaning you ask for it, and you're told no by anybody in the system, the CMO, Perform Care, or if anything gets the review for the CSOC office at the state, if anyone says no, that's a denial. If you have a service, say you're receiving in-home services or therapeutic services in the home for a certain number of hours per week, and those hours are being reduced, or if there's a complete termination, those hours are getting reduced from 3 hours a week to 0, any of those are an event that should trigger a written notice to you. And that written notice should explain exactly what the decision was, right? What was the decision about your care? It's being reduced, terminated, or your request is being denied. Why that happened, a brief explanation of the standards that applied, right? Oh, because you've maxed out the hours, and here's where the standards of the maximum number of hours come from, or because you don't meet clinical criteria. And most importantly, instructions on your right to appeal. Because oftentimes families come to us saying, I had no idea I could appeal. Even though you can go through Perform Care's website and find instructions about how that process works, families often just don't know, or in that moment when services are suddenly leaving the home, they don't. It's a moment of panic for them, and they don't think about it. I think Molly already talked about some of the processes, so I don't want to retread what she laid out, but I laid out a little bit of a flow chart on the slide here. That the first step typically is going through the reconsideration. That happens at Perform Care by calling Perform Care. Because I'm a lawyer, I would always recommend following that up in writing, making sure that your appeal doesn't get lost in the system. Though we don't see that being a major problem in the system as it stands, it's always a good idea to have a written record. If Perform Care can't resolve the problem at that first step, by intervening with the CMO or with the providers, the next step is to go to the Children's System of Care appeal. This is a formal appeal process that can be transmitted through the Department of Children's and Family to the Office of Administrative Law, where a hearing can happen, meaning you get before an administrative law judge, who is essentially a hearing officer, to dispute whatever it is that was denied, terminated, or reduced, and make your case and be heard. Ultimately, that will result in a final binding decision that will decide what should have happened with the services in your case. In the school world, the good news is there's the IDEA, the Individuals with Disabilities Education Act, that formalizes a procedural protection and a set of due process rights for students or their families when a service is denied, reduced, or terminated in the form of an IEP. So if there's a disagreement with placement, for example, between the school and the student and their family, there's an option to go through mediation or to go through due process, where to the Department of Education, a case can be transmitted again, ultimately to the Office of Administrative Law for a hearing, where an administrative law judge can hear the case, hear the sides, arguments on both sides, and make a binding decision about what should happen, which ultimately resolves that dispute. Both of these can be tricky or confusing. So again, if you find yourself in a pickle where you think you might be going down the appeal process, I would encourage you to reach out to my office at Disability Rights New Jersey for some assistance. Again, even if what you get is advice, some help navigating, oftentimes families don't even know where to start. And so that can be valuable to you as well. And one final tip I want to provide, I know we're running a little bit short on the clock here, is if you're ever working with a CMO, and CMOs are diverse, Not all follow the best practices, and every case manager may have a different level of experience. There's a lot of discussion about turnover, and managers may be new to the world and may not totally understand what's going on. Oftentimes, that family-centered or the person-centered approach may falter a little bit because a family may not know what's available to them, what are all the choices on the menu, and a care manager may not actually know exactly what all the choices are on the menu. They may kind of have a recipe that seems to work for students, especially or youth with IDD. It's always a good idea to ask, right, what other services exist, right? What are they? And do your own research, but ask the care manager, what are they? And how can my child get those, right? That will help make sure that there's not just a kind of, we have like a one size fits all plan here in, County X, so that you can say, oh, well, actually, the intensive in-home services, therapeutic services, we don't need that service, but what we really need are respite, right? We need a little bit of a, backup plan here for care situations. But if you don't know that respite is out there, you wouldn't know to ask for it. And that might not, even get you into the place of even starting having the conversation with your CMO about getting it into the plan, getting it approved, or if it's denied, even knowing that you can start down that appeal process and triggering the notice and appeal process there. I apologize for talking about 1,000,000 miles an hour. I hope that I was able to get a lot of content in quickly, and will happily stick around for Q's and A's.
We're going to go to Christine. If you don't mind, one quick minute before Christine starts. Michael is talking about families absolutely exercising their rights to mediation and due process if there is a dispute, and we support that. But there's some space in between there that we have supports at the Office of Special Education that I want you to know about. We have the Special Education Ombudsman, who is there to answer any questions, kind of pave the way, maybe communicate with school districts if that can help facilitate a solution. We have free facilitated IEP meetings where if the district and the families are willing to come together, we have trained facilitators who are neutral, are not employees of the Department of Education, who can come and help create a child-centered IEP and maybe help settle some of those concerns or issues. And then we also have family support specialists, and these are professionals at the Office of Special Ed who exist solely to support families. They do not speak with attorneys or district staff. They are only for families to walk them through what are my options if I have a concern. So I don't want you to think that there's nothing, it's here, I don't agree, and now I have to file. That is obviously an option that you have, and you exercise it when you need to, but we also do have supports in the Office of Special Ed.
That was actually a really great segue to the work of our office in the Office of the Ombudsman for individuals with intellectual or developmental disabilities and their families. So I know in the interest of time, I'm going to try to keep my remarks brief as well. And there are certainly a few slides that we can cut out from the talk because I know we want to get into the Q&A. But I do want to just talk a little bit about the office because we're relatively new. And I know many of you in the audience and probably joining us virtually have worked with us. But for those of you who don't know, we're a relatively new and small office. The ombudsman is Paul Aronson, who was appointed by Governor Murphy about 6 years ago when the office was created. And I joined him about 4 years ago as the office's first support staff. And what is unique about our configuration is that the majority of us have lived experience in the intellectual and developmental disability realm. Many of you know that Paul is a sibling. I'm a mother. I have a 26-year-old son with autism who is very well served by his school district, age 3 to 21. I also do have experience in the CSOC realm. When my older son was 17, he had a pretty significant medication-induced psychiatric crisis, which brought us into the perform care system. So I bring that that guides the work that I do every day, because I certainly understand the challenges of trying to learn the CSOC system array in a hospital, in an ICU with my son on a ventilator after a crisis. And Paul thought it was really important that this new office should have that lived experience. So just know that when you're contacting us, we are with you as family members and as individuals with disabilities. And again, the office was formed by legislation in 2017, signed by Governor Chris Christie, and again, operationalized by the Murphy administration with Paul's appointment. And the legislation that creates us really wants us to focus on three major things. We do systems advocacy and navigation. That's a primary role that we do. So our office offers information and referral. Kim mentioned the Office of the Special Education Ombudsman. We connect with them regularly on routine special education matters. Molly mentioned the Children's System Office of Advocacy. We're often contacted by families who may not necessarily have an intellectual or developmental disability, and it may be more of a mental health matter. We often then refer them to the Office of Advocacy to help resolve some of those issues. Paul and I do a lot of options counseling with families. So Kim mentioned that, you know, there's certainly room in the system to help mediate problems before you get to fair hearings. We're another resource. Unlike Disability Rights New Jersey, we're not attorneys, but we are advocates. So we will talk you through on any issue that you have. The legislation also mandates communications coaching. So as a mother advocate who knew how to run an IEP meeting or working with a CMO, we've certainly helped families who are encountering problems work proactively in those systems. You're having a problem with your care manager. Do you know your care manager has a supervisor? Write an email. Let's call a meeting together. We help families write emails to resolve problems and set those meeting agendas. Our advocacy also does, as Molly and Kim have both also mentioned, our office is in regular communication with government partners. So if you're having an issue with the children's system of care and you've reached out to us, we're letting her team know as well. And then again, the meeting support. So you as families have the right to involve anyone in your child family team meetings or your IEP meetings. That includes our office. So one of the things that we've heard both from care management organizations as well as families is that if there is a problem and communication is breaking down, sometimes the presence of our office helps course correct that. And that's our ultimate goal, because we certainly understand that there are going to be problems that arise. That's why our office was created. But we do, with the individuals and families in mind, we want to be a resource to help correct some of those issues. And then in the broader, the other two things that we do is that we recommend system-wide improvements, and we ensure that the family's voice is heard at every meeting and at every seat at the table. And again, we do this by working primarily with individuals and families, but we also work with advocacy groups, providers, care management organizations, and other government officials. And one of the things that we also are required to do by our legislation that mandates the office is we issue an annual report every year. And what that does is it summarizes the services of the prior year, as well as we make system-wide changes, recommendations to change the system. You know, another thing that is unique about our office is that we don't live in one particular department, and it was done on purpose. The Special Education Ombudsman is housed within the Department of Education. We are what's called an in but not of Treasury office, and what that means is that we operate with independence. So what that does is it gives us a system-wide perspective. as well as a lifespan perspective. So we will work with any individual or family from birth through the adult system. And we can just jump ahead to the persistent challenges slide. And this has been alluded to by Jarrett and others. You know, there are really four main issues that come up across the lifespan, including with the children's system, and they're around the workforce shortage. We feel that workforce shortage often leads to the abuse and neglect that also our office is made aware of. We consistently see problems with complex medical needs. And then also within the children's system, autism with severe challenging behavior is brought to our office on a daily basis. So we know that there are bed shortages, and we will certainly work with individuals and families in the children's system to really amplify the advocacy when individuals and families aren't getting the supports they need to remain home successfully. And so we left some time for Q&A.
I can go a little over. So let's go through some questions. There's a number of them that have come through online. And I think I need a microphone so everybody can hear me. I'll come up here. And then if there are questions in the room too, we can certainly take those. I think Carrie usually is the one that comes around with the microphone for that. So, all right, can you all hear me? So I'm going to go through a couple quickly because I think they've sort of been answered, but I just want to highlight them. So the first question was, CSOC, is CSOC the same as Perform Care? I'm familiar with Perform Care, but I barely hear about CSOC. So I'm just going to reiterate and you can jump in. Perform Care is the front door to CSOC, but the children's system of care is the main focus. It's a main piece of it's the pie. Perform Care is the way you get in and the way that the quality of services is managed. Would that be a fair answer?
Just add to that.
Sure.
I do think it is important. Well, I'm delighted that people recognize Perform Care. It is very important that families also understand that this is not a standalone system without oversight and accountability to the government of the state of New Jersey, right? And so I hope that what we were able to share today are some of the other the avenues for access and communication to those of us who work at the division of the children's system of care, and understand that relationship, that they really, Perform Care is contracted by us to fulfill all of their responsibilities. So I hope that's helpful.
And I'm just going to do a commercial quickly here. The Regional Family Support Planning Council is planning 2 forums over the course of the next, I as an educator still function in school years, but on really CSOC 101 and how to understand the system and all of the levels of it. So we're, please think about attending that because it does get confusing and people use those things interchangeably. And I think people do get confused. The next question is about maximum hours of services per week. So I'll just highlight one thing that you said, that the respite hours have been increased to 90 hours per 90 days. And in terms of other types of services, I'll let you guys answer.
So that's a little bit of a hard question to answer because it really can vary by service type, what the authorization request is, things can be adjusted. So what I would say is that if a family has a question about whether or not they're receiving the appropriate, and I think this goes to what Michael had shared about amount, duration, and scope, and if they feel that the amount or the duration or the scope are not meeting their child's needs, the first step would be to bring that back to and discuss that with their with the CMO. Because then the CMO is able, if we need, I see this on a regular basis, maybe not every day, but several times a week, where there's a conversation and then there is a request to adjust or increase the hours of availability. And if And I would say that if a family feels that the CMO is not hearing them or being responsive to their needs, that would first be in that instance, a call to perform care would be the first step. I also want to say I review, not to only several members of our team at CSAC, including myself, we review every complaint or quality of care concern that is provided to perform care. And so because we're also often involved in the follow-up to address and remedy those issues, but we monitor those very, very closely and we look for trends.
Thank you. Our next question, I'm going to paraphrase this a little bit, but so if a case is opened with a CMO, a care management organization, am I correct that the care management organization then makes the referral to the FSO, the family support organization? So I'll start there and then there's more to the question, but.
So it's twofold. Is that on?
Yeah.
So the FSOs are available to the community without a CMO. That's not always understood. So that there is a way you can contact an FSO directly without going through perform care. So that's one distinction.
So I'm going to ask the question now. So
Sure.
they'll open a cyber account?
No.
No. Okay. So that.
Separate. But to answer the question more directly, there's an expectation that when a youth is open to a CMO, that FSO is also offered to them and that connection is made should the family elect to have it. It's an automatic part of the process.
Okay. And I think it's important because I do work very closely with the Essex FSO. I think it's really important to understand, and if I'm wrong, you're going to correct me. The CMO, Care Management Organization, provides services to the family and to the child. The purpose of the FSO is to support the caregiver. Is that a fair assessment?
Their primary workers are called family support partners specifically for that purpose.
Okay, so here's the second part of the question. So the family, if they're open with the CMO, the Care Management Organization, and they want the services from the FSO, the Family Support Organization, but there's a waiting list for the FSO. Meanwhile, the CMO, Care Management Organization, closes them out. So based on what you're saying is they still would be eligible once they came off the waiting list for the FSO to receive that caregiver support.
So I think I need to take that one because it does really implicate the waitlist issue.
Yep.
And so one of the challenges that we have had for a number of years, and I can tell you that we've taken numerous steps to try to address and remedy this, is that the financing for most CSOC services is through the Medicaid state plan or waivered services. This means that they are essentially an entitlement benefit, and that means that the funds that we need to increase our capacity are available through those rules. The family support organizations are contracted as they have cost reimbursement contracts. They are not and their services are not part of the Medicaid state plan. And so as we have seen the unprecedented growth in the number of youth enrolled with CMOs, it has created a lot of pressure on the FSOs to be able to identify that family support partner. So we have been working with our family support partners over the last few years, as we've seen like those tremendous levels of growth, on ensuring that they are adhering to an appropriate sort of triage in terms of how they're making those individual partners available, because we were beginning to see a situation where the family support partners, and if you've worked with one, you know this, they will go to the mat for a family. They have done extraordinary things to work with and support individual families. And we had to institute some controls because the family support the peer partners, the number of families they were working with was growing beyond what was reasonable. And, we have to remember that they are also family members who need to put their own oxygen mask on first as well. And we felt it was very important that we institute some limits in order to really protect their health and well-being and not have unrealistic expectations about the number of hours that they could work, the number of families that they could serve, that they can serve, and better to have, families really through this triage so that when they're working with a family, they can really provide that support, and then they may need to transition so that they can serve another family. And I can assure you that ongoing conversations about how to rectify the situation continue. I don't have a perfect solution for you here today, but we do know that this is a challenge. And then there are some families who are offered that peer partner and they don't want, they decline it, and that's okay, it's not a requirement. If the family is no longer open with the CMO and they may no longer be eligible for those services, and I say this even if you're open with the CMO and you may be waiting, and you may also be open with you may have a peer partner, we strongly encourage families to connect with mom to mom. And I don't think I included that on our resource page, but it is so important because mom to mom is also able to, it's free. They're also able to offer not just responses to individual calls, but to work with parents on their wellness plan. They've developed a wonderful model and they also have some peer support. So that's another resource that we want to make sure families are aware of.
Okay, thank you. So just to put a button on it, you can get FSO services if you are not currently open with CMO.
You can be involved and access those community services, but you cannot, you're only eligible for the individual peer support if you're open with the CMO.
So that's a distinction.
Or mobile, thank you.
Or mobile. Dottie. Wait, Dottie, we need a microphone for you.
Christine, I think the Ombudsman's office does an amazing job. Our report is always on point. I look at it again this morning, and one of the things you talk about is appeals through Medicaid. And some of the examples spoke to me because I see this all the time. A family was approved for 3 physical therapy sessions. They had those sessions, but the notes indicated there were no improvement and no further plan. When they appealed for additional services, additional sessions, they were denied because there was no plan and there was no forward plan, and therefore no medical necessity. Jared, does that sound like the right conclusion, or?
So I think that is a question that would really need to be posed to the Division of Medical Assistance and Health Services, because that's probably, if it's coming through Medicaid managed care organization, they would really be best to speak to that.
Okay, so I should have been more specific. Who determines medical necessity?
So it really depends on who the payer is and what organization within the larger system is responsible for those services. So for example, if an individual, and Michael may also be able to help us out here, but if an individual, if this was an individual who was enrolled in a managed care plan, one of the Medicaid managed care plans, then that appeal process happens through the MCO and with the Division of Medical Assistance and Health Services and the Department of Human Services and Families. And I don't have the line of sight and familiarity on how that process happens. So I would defer to them to provide that information, but that's certainly something we can discuss in further forums and perhaps have one of our colleagues to be able to speak to that with some specificity and clarity. So I don't want to misspeak about that process.
Could I jump in from the web here?
Yeah.
There's a case, it's almost 10 years old at this point, Jimmo versus Sebelius. The case is about Medicare, but I think the law holds just as well here in this world. And just hearing the tenor of that question, it's right. What if a therapeutic service is not improving somebody, right? What if there's not, you've plateaued, so to speak? That was the problem in that case. Regardless of who the decision maker is on whether it's medically necessary or not, the outcome of that Jimmo case was that improvement is not part of medical necessity. If a service is preventing you from losing progress, right? Even if it's habilitative, right? Keeping you where you're at, that's something that under Medicare should still be approved. And you take that analogy right over to the Medicaid world that we're working in now. And And it holds true too, especially in the world of people with intellectual and developmental disabilities, where the reality is often, right, you're trying to avoid losing functionality in whatever the area is, not necessarily going to gain functionality. So that's a pretty common theme. We hear that a lot in a lot of different places that, oh, well, you're not going to make any more progress, so we're going to cut the service. And that's really not the legal standard to apply.
Thank you.
All right, I have a pretty quick question here. For family support service application for respite, it's good for a year. The question is, does it get reauthorized, or is there a need for the families to reapply?
Yes, at this time, families are required to reapply after 1 year. And I want to say a little bit about why that is, because I know that it's another thing on your to-do list that you do not want to do. And the reason that we do require this is that children's needs can increase, like their needs can change. They do change, right? They change over all of their developmental stages. And that part of what happens in that application process is determining whether a child's needs are moderate, low, moderate, or high need. And the reason that is important is because we want to make sure that when a child has been approved for respite services and the providers are, so the child is approved for respite services, and then to connect with a provider, the provider has to accept that referral. And we tell our providers that they must prioritize those highest needs youth. So I think that's an important point to understand that we're not doing it other than to make sure that to make sure that youth who have those higher level needs are not being left to languish on a wait list while youth who may have less complexity are being served. So that's really what that's about.
Okay, so the next one's a hotbed issue. We hear a lot at the Family Support Organization. So in this person writes, in our experience, the more severe or complex need children are quickly checked out of receiving CMO services and other services, as there is a long wait list for appropriate service providers. CMOs seem to tell families that they are dropped when no service. So if there's no service provider identified, there's a little bit more, so I'm just going to finish it up if I could. So if there's no service provider available or identified for a family, it's not that the need has gone away. It's just at the moment we can't find somebody to provide that service. Where am I here? So families are dropped when no service is provided while families wait for availability. This seems to improve CMO results, but it's devastating to the families who have to take time to request services and get on waiting lists all over again. We hear this one a lot, that you have kids with maybe severe behavioral needs, and a service provider might come in. Sometimes the service provider is identified. They come in, they take a look at the kid, and they say, we can't do that, or we can't identify the right service provider. And then the CMO terminates services because there's no services, no Medicaid-based services being provided. So that's a common theme that we hear a lot.
So I want to be very careful about how I respond to this question, because it's a hypothetical as it's been presented, because in order to really respond to a situation like that in the appropriate way, I would need to know very specific, there would be more specific information that I would need. I am not aware of situations in which an individual family has simply been terminated or dropped from, to use that language, dropped or terminated from the CMO because they're not providing other services per se. That doesn't mean it hasn't happened.
Mm-hmm.
And so I think that there are situations, and this happens, there are also situations that happen now where a youth may be open with CMO, they're receiving all of their autism services through their MCO. So the CMO may not be providing or working to get that authorization through the CSOC system, but that child is still actively engaged in services and has a plan of care and continues to work with the family. So I would suggest that if a family has a concern about a CMO's recommendation for transition, that is something that should be escalated through the complaints process. And I am aware of situations where there are many situations where where families are frustrated about the length of time on the wait list, as Jared mentioned, and we don't have time today, I think, to go into some more depth about the workforce challenges. But I do think it is important in another session that we have an opportunity to talk about, what those challenges are, where those pain points are happening. But I really implore families that if you're questioning a decision that is being made, that you raise that up first within the CMO organization. If you're not getting satisfaction, that can go to Perform Care. If there's a sense of urgency, then that can also come to the Office of Constituent Affairs.
I'm just going to make a comment. We hear a lot of confusion about ABA services. That seems to be a very confusing issue for a number of families. So sometimes the CMO will come in and it's clearly ABA services that are needed. They'll refer back out to the MCO or to a family's private insurance to get those services. And I think families have a hard time. They're not understanding that they're getting their needs. They might be getting their needs met, but it's not anymore through the CMO. It's through the MCO or the insurance. And I think families need a clearer explanation of that as we move forward.
Yeah, I agree. And I think this was one of the challenges with the carve into the managed care plans. On the one hand, what that accomplished is before April of 2020, the only way that children who were enrolled in Medicaid could get their ABA benefits was if they had eligibility for intellectual and developmental disability services and met CMO criteria. So that change was a tremendous benefit. So, and improving access to ABA services for you and was very sound because we wanted to ensure that children who, at any age, as they were being identified, could get earlier access to those services. But it did add another layer of complexity. And to your point, the payer landscape is very complicated. So I appreciate the fee. So it's a benefit because there are many, many more children now who are able to access ABA through Medicaid than was the case 5 years ago. But it has made things more complicated, especially, and this is an issue that we are aware of, and we're in discussion with DMAHS about this, for children who are moving between the MCO and our state-only coverage. So we understand that there are some additional concerns we need to address there about coordination across payers so that for continuity of care. But having said that, I hear what you're saying. And I think that that one of the things that I think would be helpful, and hope if you think like, no, that's not going to work, is that we really have a responsibility at the state to develop that guidance and a fact sheet in simple language that the CMOs can then share. I'm sorry,
That's okay, I don't even hear it.
sorry, my daughter is texting me. Sorry. So that everybody is getting that same message and that it's being shared in an accessible way. So that is absolutely something that will be a takeaway from today, and we will work on that.
Yeah, I think that's a really tricky issue. And I think what just contributed to make it trickier was that change came out as the pandemic started. So people are a little overwhelmed at that point in time. The other thing that I will say as an advocacy issue that we have heard from many families is it would be helpful if the CMO is there and then referring out to the MCO or the insurance for those ABA services. Many families have said it would be really nice if they could help point me in the direction of providers. So I'm not, spending all my time trying to find a provider. Yes, they have to get approved by the MCO, but it would just be helpful as an extra little support if a referral to specific providers in the area was provided for them. So, okay, I'm going to try and skip over a couple that I think we've answered. So here's one that we can what are the levels of assessment for out-of-home benefits or support in that areas? I think you kind of addressed that goes through the CMO. It's referred to Perform Care. It's bounced up to you. And we're going to cover more of all of that in detail in our forum, so please look for those. Dates aren't established yet, but they're coming. When will the pilot for the IMTS end?
Well, I'm happy to say that that's been a bit of a moving target because originally we were told we only had 24 months to spend the federal dollars. That window has been extended a few times. And so I don't have a specific date today because we literally a few days ago, we were advised that the feds extended that again. And so our goal is to continue it as long as we can.
And at some point, will you be able to share how that worked and how it benefited the families and tell families a little bit more about that?
Yes, I think, as I said, we are conducting an evaluation. I also would want to add that it's a pilot, and one of the things that we did in the first, I think probably the first month or two, was, we were very excited thinking this is something families are going to really want. And then as the CMO started to work with families around a referral to the IMTS program, we found that there were a lot of fears and concerns about, if I take this, what does this mean with being on the wait list? And we very, very rapidly modified some of the sort of like eligibility rules in order to ensure that families could access these services without losing the number of days that they had been waiting for an out-of-home placement. And so we shifted the outcomes a little bit from not only, wherever possible, if we can maintain the youth in the community, that is a very good outcome, but also if a youth is involved with this program, and then when that they might actually require a less intensive out-of-home service and enter an out-of-home program at a less intense level of care. So I think that we will be sharing, when the evaluation team is ready to share some of the outcomes around the implementation, the ways that we modify the model to adapt to the needs of the families that we've been working with, and then to look at some of those outcomes, we will be sharing that.
Okay, I'm going to go quickly over this one about an amendment to the IEP. Your first line of defense would be to put in writing to your case manager that you need to change in your IEP. If that doesn't work, I think Kim did a really nice job of outlining some of the support services. I happen to think that the idea of a facilitated IEP is highly underused.
Yes.
And that also reaching out to this special education ombudsman is also probably highly underused as somebody who worked in the school districts for a long time. Let me just keep going. What is being done to educate families when the district doesn't have, there are a lot of districts that don't have functioning CPAGs. They have them kind of in name only, but they're not really functioning. So how can we reach out to families through the school districts? I do think you said one thing, that you're going to be talking to the directors about that, which I'm really happy to hear, because the directors will come back to their child study teams and provide that information. It is true that every district doesn't have a functioning CPAG. Do you want to add to that, Kim?
So it is required in federal and state law regulations that a district has a functioning CPAG. That is first, it is kind of, you have to have families that want to be involved with the CPAG, right? Because it is a family run. The school district is there to listen, but you have to make sure that there's some enthusiasm around it. But we do complaint investigations around this a lot. We monitor for this issue. That's one of the things, because family engagement is so important. So if you have in your district, there is no functioning CPAG, and you could call the ombudsman, we'll reach out to the district, or you can file for a complaint investigation and we'll go out and take a look and I tell them they have to get one together.
Okay. Lisa.
Wait, question related to that, before anyone were to reach out to the ombudsman, is there someone in the district who could answer that question and say where that would start?
The director of special services.
Right.
Reach out to your director.
Thank you.
Just as an aside, when you're having issues with the school district, ask questions. And always keep in mind that it's your IEP meeting. That's my commercial.
Yeah.
But, I'm gonna gloss over this because we are gonna cover this in the CSOC 101 forum, but there's some questions about aging out of the CSOC system and into DDD. And how is that transition managed? I think there are a couple of issues that have come up in the past with that. I'm looking at Nay right now. It's very tricky for kids that are in out-of-home placements. That seems to be one tricky hiccup with the system. And I know we're getting close to the end. I'm going to try and wrap up questions, but I know another tricky thing is for 18 to 21-year-olds, you have to apply to DDD and then get kicked back to CSOC for services, right? The application doesn't go through Perform Care anymore for 18 to 21-year-olds. It goes through DDD.
So, yeah, I'll explain if I can, I'll try to explain this with as much clarity as I can.
And keep in mind, we're going to go over this in much, this will be in the future forum in much more comprehensive explanations.
So and this architecture is in part, it's not in part, it is really driven by the statutory and regulatory authorities across Department of Human Services and Department of Children and Families. So if a child is under the age of 18, you come to the Children's System of Care to apply for eligibility. If a child, whether a child did or did not establish eligibility before the age of 18, person anticipates transitioning into the adult DDD system, then the application must be made to DDD. And that can start, that process can start after the age of 18. So it is, in most cases, it is the process is more simple and straightforward if that young person is coming to DDD having already established eligibility as a child. What I think you're also referencing, and these are often very, very difficult situations that may happen in a crisis situation. There may be a young person who did not establish eligibility before the age of 18 with the through the Children's System of Care. In order to receive functional services through CSOC, they must go through the DDD eligibility process. And once they've established that eligibility, then they can be served. However, while that eligibility process is ongoing, if they're between 18 and 21, they can still be eligible for CMO and for some of the other services that don't require IDD eligibility. So, and it can be a very challenging situation because often that individual is in crisis.
Right. We have a number of other questions. Some of them, the content has been cleared, but we're going to have to kind of cut this off at this point. If you have a question in the Q&A and you feel it has not been answered, please reach out to the council and we will get back to you with that answer. Everyone who was registered today, as well as everyone on the NJCDD mailing list, will get the information about the upcoming forums where we will really take a deeper dive into understanding the system and how families can access the system. And we also plan to do a forum on that very important transition from children's services to adult services, because that's a big one. And a number of us have successfully negotiated that already. And we want to make sure we help families do that. I really want to thank everyone on the panel, Molly, Jarrett, Christine, Kim, and Michael. Your time and your insight and the information that you have given us certainly is helping many families. And I think most importantly, it's establishing an open line of communication and knowing who the people are that can assist families and provide the services. So we are extremely grateful for your time on a Saturday morning, which we know you probably had some other fun thing you could have been doing. But thank you very, very much for your time and your expertise. And thank you to everybody that attended this. And once again, if you feel you didn't get your questions answered. Kyoko, can you put in the Q&A where they can email us?
I already did.
I knew she did. Nobody in the whole world, except for maybe Carrie, who ties her, can put resources and information in a Q&A or a chat faster. So we are eternally grateful for them. We would not survive without them. So thank you, everybody, for your attendance and your participation. We are really happy to see you all here today.
Thanks for having us. Hey, Kim.